For those of you that do not know me, my name is Lee Gross. I am a practicing family physician here in Southwest Florida. Originally from the greater Cleveland area, did my undergraduate at Ohio State University, went on to work at the Cleveland Clinic Foundation in their cardiology department for about 3 years doing clinical trials. Went on to medical school at Case Western Reserve University in Cleveland, did my residency at University Hospitals in Cleveland, and came down to Southwest Florida to put out my shingle, and I'm presently practicing independently in Northport, Florida.
I never heard of Northport, Florida. Is that around here?
Northport, Florida
is the largest?
It's about an hour north of here, which I planned for 45 minutes.
By landmass.
Yeah, so Northport is the third largest city in the state of Florida.
Excuse me.
By landmass. We're in southern Sarasota County. We just passed the city of Sarasota in population. We have 60,000 population. The city of Sarasota has 55,000. We are the largest city land-wise that does not have a hospital in the state of Florida, but that's a topic for another conversation. We did apply for one. We received a certificate of need in 2004, and it was overturned by an administrative judge. And since then, we still do not have a hospital in the state of Florida, or in the city of Northport. But I'd be more than happy to come back another day and talk about that topic. I understand that it is the position of this commission to seek ways to provide affordable medical care for the residents of Florida, and to do so with an open and price transparent fashion. And what I'd like to share with you is that we've been doing this in our practice since 2010. We created a direct primary care program where we have a membership-based program into our practice. Some people would look at this as a concierge, but it's more like a concierge light or a concierge care for the little guy. So to tell you a little bit about our practice, it is not, it's strange to have a healthcare company named Epiphany. Well, we did in fact have an epiphany, because we were running through the rat race just like every other physician practice in the state, trying to deal with insurance claims and trying to fill out forms and get prior authorizations and step edits and just do all the nonsense that has nothing to do with patient care. But it was consuming a tremendous amount of resources in our practice, and we just said, you know what, there's got to be a better way to do this. And so one day we were approached by a owner of a small company in town. It was a heating and air conditioning company, and the guy said, hey doc, I have 10 employees, and all 10 of my employees see you as their primary care physician. My insurance is going up to about $1,000 per employee to see you. Why don't I just pay you directly, and then I'll take out a catastrophic insurance policy on you all, and if anything comes up, I'll just pay your catastrophic premiums, and I think we'll all still come out ahead. So that was our epiphany, is that, why are we insuring primary care? Why don't we have more direct relationships with our patients? Because that is the stuff that starts driving up the cost of health care. Anytime some person that doesn't need to be touching the patient touches the patient, the costs go up. So for example, if I wanted to give you $1, the most efficient way to give you $1 is to hand it to you. It would not be to hand it to you, to pass it to every single person on this commission, to take a penny out of that $1, and then for that process to do that, you have to pay a 60% administrative fee to collect that money. That is not efficient. So the efficient way is to do it directly. What we're selling is we're selling time. We're selling brain time. I'm not putting in a $10,000 hip orthotic. I'm not putting in a $100,000 pacemaker. So why is time so expensive? It's because we're doing it wrong. We're using insurance wrong. So our membership-based program in our practice, when you join a health club, you don't pay to use the sauna, you don't pay to use the gym equipment, you pay a flat monthly fee and you utilize all the services in that facility. The same thing with our practice. After you pay your flat monthly membership fee, we don't charge fee for service for anything that we do inside of our office. So if I have to do a cortisone shot, if I have to take off a skin cancer, if I have to do an EKG, I don't charge a penny extra for it. What we've also done in order to make this work is we needed to reach out around us and find out what services does a primary care doctor need to effectively do his or her jobs correctly. We need access to affordable labs. We need access to affordable imaging services. We need physical therapy services. We need access to reasonably priced specialty services, or at least the price transparency to know what we're getting our patients in when we utilize those services. So we reached out to like-minded providers in our community and said, if we sent you a patient, they agreed to pay you at the time of service, what could you sell your services for? almost like Priceline does for hotels, where they say, you know, if you have a hotel room that's not being used, and we can guarantee you that we're going to fill it, and you know, what can you sell it for? We do the same thing with our imaging centers and say, you own your CT scanner, it's not running 24 hours a day. If I sent you a cash-paying patient and they agreed to pay you at the time of service, what could you sell your CAT scan for? And just put them in paper. Give us a price. Let us know what these things are, and you'll see down the line what the prices we're seeing here. It's pretty amazing. So whenever we start getting into these talks about free market in healthcare, you know, what people say is, well, we tried the free market in healthcare. Well, the free market in healthcare is this. So you get a Black Friday special for a television for $200 that used to be $750. You know, that's the free market in action. Competition, innovation, improved technology. For some reason in healthcare, that's the only field in the world where technology increases the cost. I have no idea why that is. In every other service or any other industry, technology brings down the cost of things or makes it more efficient. But it's the opposite in healthcare. So in healthcare, what you really see is this. You see constant rises in the cost of healthcare. And you know, we all heard the story about the hedge fund manager that purchased a pharmaceutical company and raised the price of the drug 5,000% overnight. And thrown out there that, you know, see what happens when you introduce capitalism into healthcare. No, that's what happens when you have somebody that's in between the doctor and the patient paying the bills, because no individual person would ever pay that kind of money for a pill. But when you put somebody in the middle that has a check that's going to pay that, then somebody is going to pay that exorbitant price. And you can do that when there's price fixing and messing with the healthcare economy. When you strip that out, it removes those things. So again, talking about we're using health insurance wrong. You don't insure light bulbs in your house. You don't insure lawn maintenance. You don't insure painting it. You don't insure gasoline for your car, the tires. Why are we insuring primary care? This is the most basic aspect of healthcare delivery. It's brain time, and it should be dirt cheap for absolutely everybody to access. And it is. So getting back to insurance, now we're going to go ahead and put primary care in a box, and we're going to call that box health insurance. And also in that box, we're going to put end-of-life care, we're going to put pacemakers, we're going to put chemotherapy, we're going to put a 3-month hospitalization in there, catastrophic stuff. We're going to put it all in there, and the primary care is in there too. What it does is it artificially raises the access point to the cost of access to primary care services. We're mixed in with all that expensive stuff. But when you strip us out and strip it away from it, primary care access costs come down dramatically. So what we basically have done, again, with our membership model is we've allowed insurance to become insurance again. We don't file insurance claims for our patients. We just take care of them. So we're not constantly treating the chart. That's not we're not treating the insurance company. That's not our job. Our job is to treat the patient. We do not charge fee for service for anything. We don't bill insurance companies for anything that we do for members in our program here. So what we charge for that is for an individual $50 per month. So for 2 people, that'd be $100 for a couple. $25 per month for one child and $10 per month for each additional child. So that's $135 per month for a family of 4, which is less than I pay for my cell phone. It's less than most people would pay for a cup of coffee per day. And for that, each person in the membership does not have to pay anything for the routine primary care services. So I'll manage your diabetes, I'll manage your high blood pressure, I'll treat your sprains, I'll do your EKGs, I'll work you up for your chest pain and abdominal pain. We'll do your mammograms, we'll do your flu shots, we'll do your pap tests, we'll do your routine blood work, all for that price. So we include for that price about $3,500 worth of stuff that would normally be charged by typical fee-for-service providers. These are the types of savings we would typically see for somebody doing fee-for-service as opposed to what we do in our office. So it wouldn't be uncommon for us to charge, you know, $250, $275 to drain an abscess that we would do at no additional fee. We do steroid injections. You got a sore knee, I have to do a cortisone shot. It's included. We don't charge extra for it. So I said I reached out to some partners in our community and got some extra good pricing for stuff. We have arrangements with cardiologists for stress testing. Our nuclear stress tests are about $500. That's a 2-day protocol with nuclear stress testing. We can do ultrasounds of the carotids for a little over $100. We can do a chest x-ray for about $20. CT scans are about $175. MRIs are about $200. And we have a price list that we know to the penny what all of these services cost. We're presently affiliated with 8 different imaging centers in 4 counties in our region. Our lab pricing contracts, and I'll talk about those in a minute, Those are with national laboratories, so our patients can have blood drawn anywhere in the country. And in fact, patients come to our office from all over the state. So I'm not the Mayo Clinic, I'm not Cleveland Clinic, but I'm in Northport. I see patients from Cocoa Beach, I see patients from Miami-Dade, I see patients from Lakeland, Orlando, because it's cheaper for them to come across the state and see me in my office and utilize my pricing than it is for them to pay cash or utilize their health insurance with a high deductible in their home areas. So this is an actual hospital bill of a patient of mine that went to the emergency room for abdominal pain, and I'm going to summarize this in the next slide. But what you'll see, this is a real bill. In full disclosure, I sit on the board of this hospital, so they are not real pleased that I travel around the country showing this. But so when you look at that bill, when you boil it all down to it, that bill comes to about $20,000. So now everybody knows that that's not what it costs to provide health care. So then you get your explanation of benefits in the mail from your insurance company. They're going to say, good job, great news, you have health insurance, therefore that price is now $5,000. I'll throw an arbitrary figure out, $5,000. Well, let's take that column one more further and say, what could it have cost, what should it have cost? And I can provide that same exact service in my office for $278. Wow. Same CAT scan, same blood work, physician exam, same day, urgent appointment, stat results, orders of magnitude difference on what something actually costs. That's the difference between the cost of care versus the cost of coverage. On the left, you see the cost of coverage. On the right, you see the cost of the actual care. So I already said that we charge $135 for a family of 4. The 2014 PPO, that's the PPO insurance, that's the Affordable Care Act Gold status plans. They're running $1,935 per month. I just looked up what it would be for my family for a silver plan before I walked in the door here, and it would have been about $1,500 for a $3,500 deductible. Again, the difference between coverage and care is about $21,000 per year. So that same family of 4, if instead of getting that gold policy, that gold policy over 10 years would cost that family about $232,000. If instead they're going to go ahead and raise that deductible up, let's go ahead and get the Affordable Care Act bronze policy, $6,300 deductible, about $12,000 deductible for a family, and we're going to go ahead and bundle that with what I'm doing. So they're going to buy a membership now for their care. They're going to have a policy for coverage. They're going to have but it's not going to be first dollar coverage for a lot of stuff. And then we're going to pull the primary care out and do a membership base for that. And we can do that for about just under $100,000 per year. So the net savings are $135,000. So then take that a step further and say, well, if everyone has a high deductible health plan, what happens if they run into a problem? Well, we've already saved them $135,000. So even if they were the sickest family on the planet and they hit that deductible every year, take $100,000 off of that, they're still $35,000 ahead and not paying anything out of pocket for all the routine care. So if they didn't hit that problem, they're pocketing $135,000. That company that approached us that has all those employees and they said, we'll agree to fund all of the deductibles for you folks if you end up in a bad situation, they're going to save $1.3 million over 10 years. And then they're going to go ahead and pay $1 million out, assuming they're going to go ahead and self-fund up to the deductible. And they're still, again, over $300,000 to their advantage. So we've been able to do this with our aggressive negotiations. We've been able to provide affordable pricing. Again, we've been doing this since 2010. This is a scalable model. This is not charity for us. These patients are treated like royalty by our practice. When we work with our specialty partners, we want them to be happy to see these patients. We don't want them to cringe when they show up on their doorstep. So we train our patients. We contract with our patients. Since this is a state presentation, I'm not going to go over the national impacts, but the national implications are potentially massive on the scale of trillions of dollars. So a couple things that can happen in Florida if Florida did want to embrace this. We did have legislation that was moving through the 2015 legislative session, and we all know how that session terminated, but just safe to say that we ended in the middle of that. But we have bills that support what we're doing. And just to briefly summarize what that bill would do, Some would argue that if you charge a flat monthly fee for unlimited medical care, you should be regulated as an insurance company because you're a risk-bearing entity. My risk is my time. If I get a run on the practice, I stay late. So it's not really a real risk. Anything above and beyond what the patient agrees to, or we agree to provide, the patient pays wholesale for everything, so it's a pass-through. It's a dollar-for-dollar transaction. What we pay for it, we give it to the patient for the exact same price. But we have legislation pending that very clearly defines what we're doing as not being regulated under the Office of Insurance Regulation, but being regulated under the Department of Medicine or Board of Medicine. So we're not saying it shouldn't be regulated. We're saying it shouldn't be regulated as an insurance product because it's not an insurance product. So that has already been, these two bills have already been introduced in both the House and the Senate in Florida for the 2016 legislative session. We'd like to see those passed in a clean manner. We've got some things that sort of get muddied up as the sausage is made up in Tallahassee, but we'd like to see that go through as a clean standalone bill. That bill we've helped pass, and when I say we are like-minded physicians that do this sort of work around the country now, have passed that legislation in 13 states. So I've managed to help get it passed in almost every state except for where I practice. We think that this is something that the public employees would be interested in. We think that, you know, as Dr. Smith, when he was here a month ago, said that you could wield that hammer, and the public employees are very powerful. I mean, this could be something that is added as a benefit for them. They could choose a direct primary care and a high-deductible health plan. That would be something that would be very easy to do. That would encourage practices like ours to pop up all over the state because then you're creating demand, and so it's easier for the direct primary care doctors to make that switch into this practice model. The state of Washington did create a Medicaid pilot program. They had 35,000 patients that they enrolled in a direct primary care practice through the exchanges up there. It started last year, was very successful. The Affordable Care Act does allow direct primary care to be bundled with a wraparound insurance policy and qualify for minimum essential coverage without penalty. Standalone by itself does not qualify, and you will be penalized if you don't meet one of the exemptions under the Affordable Care Act. One of the big things in the future I think you're going to see are smaller businesses attempting to self-fund for insurance. We're already seeing it nationwide. Pretty much every company over 1,000 employees, about 97% of them nationwide self-fund. We can bring that self-funding way down to a low number of employees. There are ways to pool risk of small employers as well. There are creative ways to do that. One of the limitations in that is getting the stop-loss coverage that you need. And there are limits varying from state to state. Some states will allow you to buy a stop-loss policy for a company as small as 1 employee. Presently, to my knowledge, Florida limits that to 20 employees. It has to be larger than 20 employees to have a stop-loss.
Just a question on how many visits per patient are allowed under your system?
Well, we officially said, and for the back, the question was, you know, how many visits per person are allowed? We specifically say 25 per member per year. That's every other.
So you'd have to go every other week to the
every other
doctor
week for a year. Nobody likes me that much.
Yeah.
Yeah.
Just wanted to make sure that the others on the panel realize that.
So that's in the contract, and part of that, again, is because we don't want to be an unlimited risk-bearing entity.
No.
After that, it's $25 per office visit, but we've never seen that happen before. But we do track that. There is one more issue that's at the federal level. There's currently legislation introduced by Senator Cassidy that basically clarifies the tax determination of a direct primary care so that it can be used with a health savings account, flexible spending accounts. Right now, the Department of Health and Human Services, Medicare, and the IRS all have differing definitions as to how that's going to be handled. So it just needs to be clarified up there. There's also a potential pilot program that allows Medicare patients to contract with a direct primary care physician as well.
Why is it that you need that legislation in Tallahassee? You say more protection. You're doing it. I imagine it's legal.
We're doing it. It's legal, but it doesn't take much to. Well, it doesn't take much to challenge that. So in other states where doctors have tried this, they have come up against the Office of Insurance Regulation that basically put orders to stop it. Now, every state that has done that has ultimately passed a law that protects them, and clearly, you know, they've looked at it and said, "You're right, this is not insurance." But it costs a lot of money to defend that claim, and you know, again, we're caring for 500 lives under this program right now. And so that would immediately terminate something like that. We'd like that protection. We think that the potential for expansion in the state of Florida is huge for this. And so I don't think people are going to invest the resources and capital into expansion knowing that it really could get challenged. So we wanted to get out in front of that and basically create our own rule set that defines what we do that's different. We wanted to define how we are different than a concierge practice. We wanted to define certain consumer protections to say, what happens if this guy picks up and leaves the state and we've given him this money? What do you do? Well, how are you explaining to people that they're going to get fined under the Affordable Care Act? Well, that's stipulated in the legislation as to how you deal with each one of these things. So it very clearly provides protections for the physician, provides protections for the patients as well.
And your patients are only paying for 1 month at a time?
Most of my patients are paying 1 month at a time. We do have some patients that pay for the entire year. It just makes it easier for them.
Right, but I mean, to qualify for your program, they only have to pay for 1 month at a time.
Correct.
So the risk is really pretty minimal.
The risk is pretty minimal. For the vast majority
Right.
that they're involved in it, 97%, it is a month-to-month.
The guy who wants to pay for the whole year, well, that's his choice.
Correct. Yes, sir.
Can I, the 13 states that are already doing this, it might be interesting for us to know who they are and see if we can check with them and see how, like we did with other things, and see if good, bad. Have they been adopted for many years? 3 years? 4 years?
Seattle, Washington probably is the longest one. That was probably one of the original ones. There's an organization out there called Q-Liance. Q-Liance does a lot of Medicaid work in Washington State. The one that really, most of the 13 passed last year. Okay, so I helped pass the bill in Michigan. I helped write the bill and pass the bill in Michigan, and that's actually the bill that's in Florida is very much based on the Michigan law. And so now we're a year into Michigan, and we're starting to see these practices pop up all over Michigan. Now they're talking about using they have big ideas in Michigan. I mean, they're referring to it as sort of the Swiss Army knife as to how much money you can save for certain programs. So if you use this to treat the inmate population, if you use this for Medicaid, how much money can you save here and there, and where else can you find savings? So Michigan is one you'd probably really want to look at.
Is Oklahoma one?
Oklahoma is one, and Oklahoma, interestingly, Oklahoma, you had Keith Smith. I mean, he basically has arrangements where if they go to his facilities, they don't pay anything. There are similar primary care arrangements that you can have to say, we're not saying that you have to get your primary care at this place. We're saying if you get your primary care at this place, it's free for you. So large employers are already doing that right now. So if a large company wants to save money, what they'll do, they'll hire a nurse practitioner, and they'll open up an on-site clinic, and then they'll get a catastrophic insurance policy, or they'll self-fund through a third-party administrator. And that's how they're saving 30-40% on their health care. And so we're able to do that down to a smaller level, because a company with 10 to 15 employees can't hire a clinic in-house, but we can allow them to do that.
What about the waiting time?
Yeah, so because of the waiting time right now is purely limited by my travel schedule. Every couple weeks I'm in a different state giving a talk. But in most cases when I'm not traveling, same-day appointments. New patients, typically, we should be able to see within a week. They're generally longer appointments, so our appointments are typically 15 to 30 minutes. Our new patient appointments for a patient in this program is 45 minutes. The main reason for that is because these people are sick. So one of the accusations is we're skimming the healthy people off and dumping the sick people on the insurance company. But to be honest with you, we're taking care of people that the insurance company has left behind for decades. And so these people have undiagnosed diabetes and prostate cancer, and so we have to see these people a lot when we first meet them to get them into shape. So these first visits need to be long and frequent. When the health departments lost their funding for primary care, we stepped in and took care of those patients because they can afford us. When the free clinics lost their funding for primary care, we stepped in. We're taking care of those patients as well. We donated a dozen memberships to the County Homeless Coalition to help people in transitional housing. So this is not necessarily just a program for the well-to-do and the wealthy. This is a program that works for everybody.
My concern would be liability. You
Yeah.
don't make enough money to hire lawyers to defend lawsuits.
Well, that's one of the reasons why we want to introduce legislation in terms of, we don't want to necessarily hire a team of lawyers to defend the fact that we should be able to take money from our patients to provide care for them, because that's what we do. But as far as medical liability, I mean, it's no more than anything else. I don't personally do hospital work. That limits a lot of liability right there.
But isn't that one of the interesting things is that if you were a traditional physician in a group or working with a hospital, you're charging that much less, but you're actually netting more total dollars at the end of the day. I mean, that's what I've been told by people that do concierge and stuff like that, is that that's the interesting part. You look at how much less they can supply health care, but they're actually making more money than they did when they were dealing with insurance companies, and that's been, for primary health care, that's been the issue. People don't want to go into that because they can't make a living, in essence, when they look at what their student loans are and all that stuff, and what it takes to become a doctor with insurance and all those kind of things. So they're actually doing better financially, is what I'm told, and I find that to be very intriguing. I mean, that's one of the parts I think that's missed in this is at that much lower, if you take the number he showed, he's giving better service because of what he just said. He spends more time with the patient. He actually knows the patients and all that. But on the flip side of that, he's also doing better as well. And I think that's the beauty of what this represents.
Yeah, and let me thank you for clarifying that. And I agree 100%. And to take that a step further, in my region, I'm the last independently owned and operated primary care practice. And it's only because of this program. Every one of my colleagues has had their practices bought up, sold, working for a large hospital corporation. We're just working for our patients.
And then I want to concierge upon that. What's the difference? I can't really tell the difference in what you just described. Is it something that you just wouldn't see unless you really understood it in the background? Or?
Well, so the concierge practice is also billing insurance on top of the membership fee. So the concierge fee basically gets you something that your insurance doesn't cover, which is maybe an executive physical and some proprietary blood test. But then and a key to the door and probably a 24-hour access to the cell phone and email. But then anything that's done in the office is still billed to your insurance fee for service at full price in a typical concierge practice. In our program, once you pay the fee, you don't pay anything. So you also mentioned about longer services. Although our practice does not specifically do this, why is it that you can't just snap a picture of your rash and text it to me and say, does this look like anything I got to worry about? Why do you have to lose a half a day of work, come in, wait in my waiting room with all the sick people, and then pay me a copay when I could have just looked at it and said, yeah, that looks fine. Or I could say, I can't get a real good picture of it. Come on in and see me. So I can free up space on my schedule and do in 5 minutes what would have taken you a half day out of your day. So it frees up efficiencies everywhere, in every way. Why can't you email me your blood pressure readings if I know and trust that you can take your blood pressure properly? Well, right now it's because I can't get paid if I don't bring you into the office. But under this system, it doesn't matter. Doesn't matter.
What about prescription medication?
So with prescription medications, there are some pretty good options out there. Now, we do network with our local mom and pop pharmacies for discounts on prescriptions. So our patients get preferred pricing. It's not a huge issue when you get these crazy expensive drugs, but we can do a lot with some very unique discount programs out there. And so we have an app that we can go through and give the exact prices of all the drugs, so we know there's no sense in sending my patient out the door with a prescription that I know they can't buy, that they can't afford. So I give them the price right in front of them and say, can you afford this? And they say yes, and I print them up a coupon to get that price. And I tell them which pharmacy is the cheapest. So those are the types of things that we're able to do. And so it's not uncommon for us to save $100 on a single prescription with that.
So is the barrier to entry with your peers that are primary care physicians, is it just the risk of opening something, like walking away from what they've got today and opening this up? I mean, because it looks like to me, so I've been on a concierge plan almost 2 years, best thing I ever did, and I think there's a definitional issue because they're not dealing anything with my insurance or anything, so I think people have different definitions for concierge, my guess. But he knows who I am. Same thing when I need to get my blood pressure medicine done. I'm taking the readings. I send them to him. He knows I know how to do it. I can go in and the problem is when he found out I was on the commission, he decided to tell me why just what you just said, why this is what we ought to be doing more of. But he indicated that he thought that primary care physicians would love to go here. It's just the risk of stepping out from something that, they're kind of making it today. Is that your assessment? Is that is that really the barrier to entry, or what holds you guys back or your peers back from doing this?
I think as a group, my peers are a very risk-averse group. And so if we could find ways to transition to this in a less risky way in terms of, okay, every one of my patients has to sign up for this program tomorrow or you can't stay here. I'm not a fan of that. Our practice is set up as a hybrid, and we sort of used our direct primary care component of it to reach out to our uninsured, to people with high deductible health plans that really needed true price transparency, needed affordable care. And so we hung on to the people that had the $5 copays that still wanted to use that service. But we are encouraging people as time goes on to start transitioning to insurance that's true insurance again. And as we show them how much money we would save them by using their insurance more effectively, we're transitioning them. Other people are saying precisely what we talked about, which is the only way you can access me is through this. So the question then becomes, on a policy level, are we then creating an access crisis by taking a doctor that was seeing 2,000 patients and now taking them to see 1,000? And I would say, temporarily you might see that, but what you're doing is you're creating a future for primary care. You're saving primary care with something like this. If a primary care doctor could go and practice what they love, what they like to do, which is practicing medicine, don't tell them how to do it, don't make them spend a bunch of meaningless time filling out forms and doing unnecessary insurance work, and they could practice medicine and make a decent living at it, you'd have to fight these people away from primary care residency slots with a stick. And that's the reaction I see when I travel around the country and give presentations to the American Medical Student Association. Is I read their blogs afterwards and say, well, we thought there was no future in primary care, but look at this. Look what we can do. This is a compassionate way that we can take care of our patient and make a living. It doesn't have to be an oath of poverty.
Dr. Gross?
Yes.
I just want, am I confused? Isn't primary care 85% of the medical care? Is that?
That may be the case, and I just don't have that number to confidently tell you. That number would not surprise me.
Okay, so if you can get primary care easier, more affordable to the average patient, it should reduce all expenses across the spectrum, because they don't need to go to emergency rooms. They don't need to go into hospitals, because their wellness is being catered to early on before symptoms show themselves, and they're getting the care that they, quite frankly, we used to get back when we used to know our doctors as part of the community. Would that not be a somewhat accurate statement?
I think it's an extremely accurate statement.
If you figure out how much federal dollars and state dollars that number is, and you start figuring out if you could get, it's not going to fix everybody's problem, if we're real about it. But if you figure out there's a subset of people that are kind of lost in this shuffle, but with a little bit of help they can afford something like this, and we keep them out of the emergency rooms and things like that, I mean, the money that we would save as a state is mind-blowing. I don't know how you quantify that, but we had a pretty good look at it, but I mean, it is a big number that the monies could at least be directed to something that's actually helping the patient become healthier with better decisions and all that, so they don't end up in emergency.
As a matter of introduction, Dr. Gross was introduced to me by Dr. Smith from Oklahoma after I went and had a cup of coffee with him after he was kind enough to come down and speak to us. What I found, then I came and visited in his office for an hour and 20 minutes, and he didn't charge me anything. But what I found is that this is a solution right here. It's in Florida. We've already got people that are ahead of the curve that can make a difference, like Dr. Smith is making in Oklahoma. So these are the kinds of things that we should try to help foster, to make sure, if their concern is that all of a sudden one day they come in and you're in insurance because you're selling memberships, for lack of a better description. That's clearly, from my perspective, not what they're doing. And I'm sure that there's ways that we could, the bad actors, we could shut them down rather quickly. As the presentation that Dr. Gross just gave, Liz can certainly send to you folks. We have that digitally, if you want to, so that you can have them in your files. But I prefer to go back. Could you go back a couple of slides, because the one that's staggering to me is the $19,000 one. The hospital compared to what he would deliver the same. That is indicative of the similar example of the cochlear ear implant that Dr. Smith made, where he's bundled that cochlear implant out the door for $36,000, and Medicare is reimbursing the hospital $94,000.
And I would also, Mr. Chairman, if you would indulge me, that go on your own website. You have 100 of these examples. You've asked people to report, price gouging. I went through the examples that people were reporting. Every one of these is this exact same story over and over again.
And we all recognize that the negotiated rate with the insurance companies and that are less than this rate. But even if it's $5,000, even if it's $3,000, pick a number, it's still a lot more than $278 on a multiple basis. Those dollars of money that's not getting spent efficiently. And if we can save those dollars by increasing transparency and making this a competitive marketplace where there is truly an open marketplace for people to provide services without certificate of need requirements, you open up the playing field, I think people will come and they will deliver the service, and the free market will help fix the problem, but it'll need the required cooperation of the legislature.
I see this also a step towards resolving some of the HMO Medicaid issues that we had, that they're coming back and saying you're not giving us enough money per patient when we're already giving them $7,000, $8,000, $9,000 per life that they take care of. I think this is a great plan. I mean, the state is basically self-insured
Correct.
in many respects, so I think a program like this would be an alternative to the HMOs.
We have to start treating the cause and not the symptoms, and that's what we've been, in my opinion, been doing for decades. And now it's just it's gotten too big to ignore the cause anymore.
Sir, now I'm going out on a limb here because, again, I'm from the military perspective, but I hear a lot of my military, the small businesses, talk about probably their long pole in the tent for solvency and sustainability and comfort is health care insurance for their employees. I see these kind of plans, and you turn around and the money saved for that small business could be put back in his business or his or her business,
But
and allows you to go on and on and on for small.
And think if the businesses could save the dollars and it reinvested into 401k and retirement plans for these individuals. So now you've solved two problems. You've taken the money that was being wasted in health care plans and put it into 401ks, which benefit the retirement of the employee that everybody wants to try to solve the problem. So it is a very big item. I myself went back and sent an email to a friend of mine. Between the two of us, we have probably 300 employees. And I said, we just need to get, I think that when I was talking to Dr. Gross, the opening up of a practice of this type to really get a foundation is about 400, I think. Is that the number you gave me?
400 probably would be a good viable number.
It's a good start. So these practices don't need, unlike the gentleman who was here before, he deals with thousands of employees. Well, obviously, 39,000 companies in Florida have less than 100 employees, I think, is what I saw on a chart. So what to solve the problem in Florida, we really need to find solutions that work for smaller scale companies, that it can implement them. So it's exciting for me because I've been looking for a solution for employee health for 4 years. First, we had to wait for the implementation of Obamacare to see how that panned out. Unfortunately, those remedies were not fiscally efficient for us. So this has given us hope that we can resolve our issues and give good quality health care to our employees. Is there any other comments from commissioners? Dr. Rosenberg, are you still there? No.
Yes, sir, I am still with you.
Oh, good. I was afraid we might put you to sleep.
Absolutely not.
Have you been able to see also the presentation on a screen?
I am not able to get the Florida channel, but I do have the handouts.
Okay, all right. Do you have any comments or questions? I sure would have, I know you would have appreciated this presentation because you know it better than we do. So.
You know, I continue to struggle. I'm convinced, after hearing all that we have heard as a commission, that transparency has a vital role to play. The thing that I would like for people to tell us and help us to understand is how that transparency will relate to a different, how that will result in a different consumer behavior. Because what we've heard in the past with all of the transparency tools is that people don't use them because they are not financially incentivized to use them. They're not seeing the price, they're not feeling the price. And so I think somehow we have to figure out how to put into our findings a way to make those transparency tools, which seem to be fantastic, as useful as they can be. And I think that this type of process where you have a concierge type medicine or I don't know exactly what the Epiphany, what we call the structure, but whatever that is, where people actually are paying for a service and receiving it, and they see that, I think that's a step in the right direction. I'd like them to talk more about that.
Just one last comment. The one thing that's interesting to me is, we've talked a little bit about how do we align everybody to have similar incentives, if you will. And the reality is this is a prime example. I mean, the person that pays for this is paying every month, and they're going to go get it taken care of because they can get in. They don't have to wait for an hour and then sit in a room for an hour and see you for 5 minutes. They probably come in, it's like where I go, and you walk into a room and the doctor's there within a matter of minutes and you're out the door. And then he's incentivized to make sure he does everything in his power to keep you healthy, because what he doesn't want to see is you coming in 25 times because you can't make money doing that, or you don't make as much money. So it's in your best effort to keep everybody healthy and not coming back, and it's in their best interest, quite frankly, to just be healthy. And it looks like to me, when you talk about aligning incentives, this is a prime example. Everybody's aligned for the better health of the individual that's coming to your practice.
If I may respond to the comments, price transparency alone is an important feature, but price transparency without market force is more of a shame and blame type approach. And so the approach to just put your prices online and, look at what you've done, shame on you. That's a lot different than what's happening in Oklahoma City, where Keith Smith is putting his prices online, and now all of a sudden the hospital down the way is saying, wait a second, I'm losing business here, I better put my prices online. And now you've got a little competition in there. So without the competition, just the price out there itself does not necessarily solve the problem. And so another issue in terms of competition is, let's just say you set up a Medicaid program and you say, we're going to go ahead and give everybody, or we're going to pay $40 per month for anybody that wants to sign up for one of these things, and we're going to pay the doctor $40 a month. If you take that money out of the control of the patient and put it right to the doctor, you've lost the market force in that, and you've set that price at $40. So if I'm up in Michigan and I wanted to expand to Florida and I was getting $80 in Michigan, why would I come to Florida for $40? Whereas if you put that, say, on an EBT card for the individual, so you have a certain amount of money to spend, now shop it around and pick your best doctor. Well, now the doctors have to start competing and justifying why one's more expensive and one's less expensive, and providing certain perks or things that they feel like their patients would benefit from. So,
Madam Secretary, who would initialize or champion test pilot program for Medicaid on a deal like this? Like I think you said Washington State.
Washington State did.
So who is that you? Who is it that would start that? I mean, that's something to me, if we're looking at,
It's a combination of factors. We'd have to get authorized by the legislature to do it. We would need to get a waiver because it would be atypical of how the services were provisioned, so we'd need to get a federal waiver. Those would all be components of it. I have made some notes, and we're definitely going to go back and double check and I actually sent an email already to staff to go and research what other states did and how that came about in those states, so that we have that information for the members for the next meeting. So.
Dr. Gross,
can I make one last 2-second pitch?
Sure.
Just Florida has their share of cost Medicaid, which has a monthly deductible that resets every month. That basically amounts to a high deductible health plan. That's great if you need surgery or if you need breast cancer taken care of, but it's not great if you need your diabetes managed and chronically. So our program works extraordinarily well with that because they can afford us. They've got a safety net if they end up in the emergency room. You already have the structure in place. Just codify it and make sure that everyone says, yes, you can see these share cost Medicaids under this arrangement.
You said, I'm sorry, Dr. Smith mentioned that the pilot program in the state of Washington, excuse me?
Yes.
Okay, could you give us some detail on that when you get a chance?
I can send you what I have on it.
Yeah, and, or send it directly to Secretary Dudek,
Okay.
because that way her staff can track that down. But if someone's already gone down this path and they have to clear all the federal hurdles that we would have to clear, we might as well follow them instead of starting from scratch. But
Okay.
is there any other comments from the commission? I want to thank you for attending today. I certainly appreciate what you're doing, and I just wish that you could multiply your practice, every 20 miles. So,
We're working on it. Thank you.
the first
for
one
your
going
time.
north. No, okay.
Franchise it.